So with this, we will turn to our next topic, which is how do you use MRD testing? And this is something where there's a difference in this question concerning clinical trials versus the approach to a patient in the clinic. And this is something that was hotly discussed at our meeting, and I think, Mary V, you missed one segment in our IMWG Summit where we had a clinical demonstration where a patient was in the clinic wanting to know the results of the MRD testing.
I know. Although I missed,
yes.
I know because I was informed about the spectacle, about the question of one patient about the role of its minimal residual disease.
Yes, yeah. So I think that this really highlights, the impact on the patient. The patient knows about MRD and they want to know should they have the test, and if they have the test, what does it mean if it's positive or negative? And so at the clinical level, there's a high level of awareness, but for us as myeloma experts, what are we thinking about it, and what do we really need to do to understand and use MRD testing? And so Bruno gave a very elegant overview summary of the ways that we can look at MRD. We have the next generation flow, we have the molecular next generation sequencing, and imaging is coming behind. We really have not standardized PET-CT sufficiently for this kind of a precise assessment, so it's coming along. We have evolved from ASO-PCR. I think people are still using the digital PCR approach, but I think we're looking mostly at the flow and the next generation sequencing, with PET-CT coming a little bit behind. And so with this in mind, Shaji took the lead in developing and is now publishing in Lancet Oncology the new IMWG criteria for incorporation of MRD assessment into the response criteria. The main point about this is that it accepts MRD by next generation sequencing and by next generation flow in an equal way, and it was selected to use a cutoff for sensitivity at the 10 to the minus 5 would be negative. And so we can talk about this endpoint perhaps later on. Also, looking at if you do this kind of testing, can it be informative at different stages of the disease? And clearly we already have information that it can be certainly give you prognostic information at each of the different time points after induction, transplant, consolidation, maintenance, even in the relapse setting, the achievement of MRD negative status can be informative. What has been quite interesting is the assessment of MRD negative versus MRD positive at the very sensitive levels. And so if we look at next generation flow and next generation sequencing, on the left here, what we have is the outcome for patients with next generation flow with a sensitivity of 10 to the minus 6. And you can see this is a pretty flat line with very few early responses. In fact, the two patients early on were probably false negatives in this particular study. But what is interesting is that the MRD positive patients at the 10 to the minus 5 and 10 to the minus 6 levels, they have an equally poor outcome. And so it gives the sense that if you're positive, and this somewhere in that mix of cells, there are cells that we're going to confer that poorer prognosis. And you see the same thing on the right using next generation sequencing, is that you have the very good patients, but then the patients with residual disease have a similar, not so good outcome. And so Bruno did a very nice job to summarize the methodologies that we have. It's very clear that looking at MRD is superior to using CR, and that we now have developed the tests that we need. But at the bottom of the slide, he emphasizes that if we are going to use these tests within our trials, NGS or NGF, they must be used in a standardized way at this point within all of our trials. Otherwise, we can't learn. And so it's important to have guidelines. Now, we already have accomplished at least the standardization of the guidelines. but we need to have guidelines about the incorporation of the MRD into trials. Do we do the testing at the same time point in transplant patients? And how about the quality of the samples? We need to have strict guidelines that if it's an MRD negative result, was it a good sample? And to have a quality assessment. And moving forward, what is most exciting is to look at the use of MRD treatment decision making. And right now, we have just started to scratch the surface. There really are not data, they're not trials where we use the MRD to make a true clinical decision. And so, although, as you see at the bottom of this slide, we have some huge achievements to get to this point where I think now we have tests, but now it's time for MRD-based clinical trials and how to deal with MRD in the clinic. So both those are challenges, but I think that the trials need to precede the clinic. Although we discovered in our survey at the meeting that despite all of this, many centers are in fact offering the MRD test to their patients and struggling with how to provide information and answers about that. So I've listed 3 questions here about MRD, and so maybe Mary V, you could start off with this. Obviously, the NGF test has been developed at your center in Salamanca with Alberto Orfeo. So you're very, very close to these data and know many details of those studies. So I suspect that you are willing to accept MRD negative as a key endpoint in trials, yes?
Yes, of course. I think that it could be a useful thing to consider MRD negativity as a key endpoint. Why? Because we have a lot of experience indicating that MRD negativity is one of the most relevant prognostic factors predicting progression-free survival and also overall survival. And the MRD negativity is achieved earlier than the median progression-free survival and earlier than the median overall survival. So if the authorities would consider MRD negativity as a key endpoint, probably we will have many new drugs approved before than if we consider, for example, overall survival as an endpoint. So I think that is a surrogate marker for progression-free survival and overall survival, and I would, of course, accept to use MRD negativity as a key endpoint. In fact, I have to say that in our new trials that we are designing in the context of Spanish myeloma group, the primary endpoint of our trials is minimal residual disease in monophenotypic complete response. Even in the trial we are doing in high-risk smoldering myeloma patients, the primary objective is to evaluate the percentage of patients in sustained immunophenotypic complete response at 5 years.
Yes, yes. So you're referring to the CSER trial for the high-risk smoldering. Yes, so that the primary endpoint is MRD negative status at 1 year, 3 years, and 5 years? Yes.
Yeah. And we hope to cure some patients.
Yeah, of course.
So we can even define the cure for myeloma, because so now we don't know what is the definition of the cure. If we achieve our objective, one myeloma patient with MRD negative sustained at 1, 3, 5 years can be considered cured.
Right. Do you want to just give us the details? I didn't show the slide of this, but this is the KRD and transplant. Do you want to give some details?
Yes, this trial is focused on high-risk smoldering myeloma patients candidate to autologous stem cell transplantation. So now younger than 65, but we are going to expand up to 70. And patients are receiving induction with KRD, followed by autologous stem cell transplantation, consolidation with the 2 cycles of KRD, and maintenance with lenalidomide and dexamethasone.
For 1 year, 2 years?
2 years.
2 years, yes. And so another point of discussion which we can get into is that if this can be curative for some patients, but I think it's not unrealistic to think that it will be. It's a constrained amount of therapy, which is attractive from a cost effectiveness point of view as well.
Well, the huge benefits of doing MRD testing, I think, with time, and Marie-V's outlined many of them. You know, for folks who've been following our conference series, we've been talking about MRD at everyone for about the last 3 years, and it seems that we've had minimal improvement. We actually have had great improvement, tremendous improvement. We all agreed we need a standard, we need a common currency, and now it looks like we are that way. Maybe we have two currencies, you know, a dollar and a euro or something, you know. So we have next generation flow, next generation sequencing. But what I think is particularly important now, as Marie-V has indicated, is that we incorporate this into trials because it's another measure of the disease. It's not surprising to us that people who have less disease are going to do better, right? Yeah. So it's not a shock. There's an intuitive nature to it, but being able to capture that so precisely, and the point that Marie-V made of it could be the earliest predictor that we have of overall survival. Yes. The concept of that, yes, it could bring drugs to approval earlier, but you know, at times it may actually, even though people think initially that MRD status might cause us to treat more, it might at some point be able to cause us to treat less. We might be able to say to a patient, look, you've achieved this MRD negative status, let's back off. Yes. As for your question in the clinic, we're one of the clinics that does it.
Yes, maybe can we come to that just in a second. So just to pick up on this point, you said that the MRD negative status would be sustained, you know, 1 year, 3 years, and 5 years. And so this has been a key point for discussion. If we use it as an endpoint, do we need the second test, and you know, how frequently should we test, so that is it reliable to have an MRD negative test, or do we need to? It was suggested, for example, for a high-risk patient, if it's negative even 3 months later, this could be helpful. For a good risk patient, probably you need at least 1 year. Do you want to comment about this type of follow-up?
I think that it is appropriate what you are saying, and in fact, the new criteria, the sustained MRD negativity, require the confirmation in 1 year.
Yes.
So I think that it's appropriate, and once MRD negativity is considered as a key endpoint, probably we will use the MRD during the follow-up to plan also early interventions, as we do now, for example, in patients with AML, to try to stabilize again the disease and to try to early treat, avoiding symptomatic progressions or symptomatic relapses.
Yeah, so this is my third question before we go back to the clinic, if you don't mind, so that obviously every patient will not be MRD negative, and perhaps even more importantly coming out of this work is the identification of the MRD positive, and then, as you say, trials at the MRD positive level, which is the new aspect of that is that you would be treating before clinical relapse. You would be retreating or searching to eliminate the resistant residual clones at a very, very low level.
And which is the principle of what we're doing now with Slim Crab, isn't it? In some respects, it's like
it's
like the ultimate slimmest crab. Right?
Yes. Now you have the potential for a new acronym here. Okay.
You know me, I'll come up with an acronym for that for sure. But that's another area that actually has not been spoken of a lot about MRD. Is saying it's not only going to help us, let's get the disease way down. We know that sadly, somehow some disease comes back, despite even for periods of time a sustained MRD negativity. Do I have to wait again until someone's getting very close to the cliff and falling to intervene? We may be able to intervene even sooner and restore that, perhaps even with less aggressive therapy, to restore that MRD negativity and keep someone in a long-term control. Whether or not it's cure, obviously, is debatable. But that's an aspect that's critical.
Symptomatology to our patients, and I think that this is important
for
their quality of life. Because myeloma, corrupt symptomatology is not only anemia. Is bone pain, renal failure. So I think that it's a key point to try to avoid crab development.
Fatigue and
Right. So my suspicion, maybe you already have some trials for this MRD level, or thinking about. Do you have?
Yes, we are thinking about a new trial in which we are going to stratify our patients after induction and consolidation according to the MRD status, to be randomized to receive maintenance or not. Why? Because we are going to discuss maintenance later, but do all patients have to receive a maintenance until disease progression? We don't know. Patients in MRD negative, really, they needed to continue on therapy, or can we stop the treatment? We don't know. So our plan is to stratify patients in MRD negative, to randomize to receive maintenance or not, and also patients with MRD positive to randomize them again to maintenance or not. Why? Because our plan is this group of patients that they are going to be elderly patients but fit patients. Our plan is that these patients have been previously exposed to second-generation proteasome inhibitor, IMIDs, and monoclonal antibodies. What is the role of minimal residual disease positive in one patient after the exposure to the most efficient new drugs we have now?
Right.
Probably this MRD positivity means nothing, and
Yes.
it can be there controlling the disease and there is not any problem. And the only way to know if this is true or not is to randomize them to maintenance or not. And
Right.
this is our approach. So now we know MRD is an important prognostic marker. Now we are going to use this parameter in our clinical practice.
Right.
How to optimize the treatment of the patients according to the MRD status.
Right. So what this says very clearly is that we are going to learn. And so to the use in the clinic, when we haven't learned, how do you view that?
I think that's no. I completely agree with Marie-V. I'm so thankful that they're doing and others are doing those kinds of studies. We're involved with them as well. We've just created this, if you will, beautiful tool. It's just come out of the factory, but we don't really know how to use it yet. So we have to test it, and we have to test it in clinical trials. I think it's one of the take-home messages today that I would say is very clear and came out clearly in our discussion in the summit, is that this is not ready for prime time. Patients should not come in and say, oh, my test is positive or negative, therefore we should change treatment. We don't know that. Your study that you just described will help inform that decision. The reason why we're doing it now in the clinic only is we're doing it.
Why are you doing it?
So we're doing it at a day 100 after autologous stem cell transplant, because we have a massive mail registry, a database of all of our patients and their clinical information. And a lot of what we're doing in these studies was informed by database studies.
Right.
So we're not saying to patients it's going to change your approach to maintenance, let's say, after the transplant. We've already predetermined that or had a discussion on that based on their risk status, based on how much disease, measurable disease was still there. But we do it because it'll go into our database, because it's not making decisions right away. It's just gain that information. It's much like we described earlier of gaining cytogenetic information. Sometimes that cytogenetic information piece, like 1Q or whatever, it's not changing what you do, but you want to know it. So then you can look back after several hundred or thousand patients and say, you know what? We're reconfirming what Marie-V has done in the trial. We found that with these 100 patients that were MRD negative, the maintenance therapy actually didn't change their outcome. And going back, we may not have to do that. So it's just another form of validation.
And I mean, obviously, it's a key thing to be capturing, because you need to have the information now, and so then you don't need to come and do it later. You know. So
and we've fairly recently introduced it in that now we feel that there is a tool that is validated that can be done repeatedly with good quality control. So I think that was an important step. But if someone is listening to this today, I wouldn't tell them that they need to go rush to their oncologist and say, you need to do my MRD testing. No, I don't think it's ready for that element of prime time yet. If it's in a center that's collecting information or in the context of a clinical trial, absolutely. But I don't think the test is changing clinical practice yet. It would be very dangerous, even though it's a very strong prognostic marker. I think it would be very dangerous if we start not treating people in MRD negative status or treating longer in people who are MRD positive if we weren't planning to. That could definitely confuse the mix and make it very, very challenging for patients.
But did you agree with one of the kind of consensus ideas was that, so for example, in this study you're talking about, you have the MRD result, but then the patient is wanting to have the MRD result as well, right? So you give the MRD result to the patient?
Oh, absolutely. This is the patient's disease, right? It's their body.
Right. So
but we have a conversation about it with them to understand.
So one of the recommendations that came up from this discussion was that before you do the test, you need to prepare the patient to say, yes, the test will be done, and then you will get the result, but we're not going to do anything about it.
Yeah.
And in myeloma, people understand that, right? We know that historically, absolutely eliminating myeloma was extremely rare. So it's different. They're understanding, a lot of these patients understand what it's like to have a little bit of disease and not necessarily need treatment. So that conversation is a little bit more straightforward with them. But you're right, if it's not preceded by that conversation and a patient logs into the portal and sees I'm MRD positive, they're going to freak out about it, right? So we want to make sure that discussion's happening.
So do you have a standardized approach to that where your patients get the results? You have so many patients with MRD testing.
Yes, but I agree with you. We inform about the MRD status, but as most patients, the first sentence they usually hear is myeloma is an incurable disease.
Yes.
So what we say is that we are going to evaluate the minimal residual disease. We are going to use a much more sensitive technique in order to evaluate if there is one positive cell among almost 1 million of normal cells. And so patients keep the information, but I agree with you, we don't do any special therapeutic approach according to the MRD status, and I think that they usually accept.
Yeah, so maybe one last comment about that, Brian, not to confuse the mix more, but you know, there's still a very small subgroup of patients, whether or not they're being what we sometimes call restored to an MGUS state or have a different genetic signature.
Right.
But we look at our Mayo database, the Arkansas database after TOL therapy, and many others have validated, although it's a small proportion of patients, probably some around 12 to 15% of patients, there are a significant proportion who actually have never really gone into a complete remission, let alone MRD negativity,
Absolutely.
who live a long time. So for example, we could look at our more than 20-year survivors of myeloma, and in that group, a lot of them, thankfully, have gotten into a very deep response, but there's some that have never gotten there. So we also want to make it clear that it's not MRD negative or bust, right?
We did a similar study, but we called to all patients to repeat the bone marrow. And what we've seen is that the immune system was tremendously stimulated.
That's right. So the immune
lymphocytes,
surveillance, exactly. It's keeping their disease in check, or what other little clone is in check. That's actually an excellent point.
This is very, very important.
But
this
that's
immune
the complexity
reconstitution.
of myeloma.
Yes.
Because I wouldn't want a patient to hear this conversation today and think, I really have to get to MRD negativity, or I'm not going to have a long-term survival or potential cure. There are people who do very well because of the complexity of the immune system.
Yes, but I mean, it's clearly there were some discussion points which made it very clear that there are a lot of aspects that we still need to understand, because Alberto and Bruno, they emphasized that, actually it was Jesus, I think, who made this comment, that despite the MGUS signature, some of those patients do achieve an MRD negative status, and they do extremely well, right? And so we shouldn't think that just because there's an MGUS signature that we should accept that.
Correct.
It may be that if we push, some of them will be maybe getting the most benefit, actually, possibly.
And this is one advantage for flow against next generation sequencing.
Yeah.
Because when you do flow, you are able to evaluate all cell populations.
Yes.
When you do sequencing, you do
just
only
focused
DNA.
on
Yes.
I think that this is one main advantage for flow.
Yes.